Hello to everybody. My name is Roberto Ronzani. I'm the CEO of the Italian Institute of Lean Global Network, and I'm here to host this session. In this session, will be presented the lean transformation of an hospital that started his transformation not so far ago, but it is his beginning of transformation. And this transformation is really strongly supported by the healthcare director, whose name is Romina Cazzaro, that should have been here today, but she was called by some big boss in the capital of Italy. And so she is replaced by Matteo Rigoni, that is a colleague of her, and with this webinar. Second person, so Matteo is here. And the second person that will be presenting you the journey is Erika Paolini. Erika Paolini is the lean agent of the hospital that started working in this project at the end of 2021. So I give the baton to Matteo that can start to introduce you the project.
Yeah, thank you, Roberto, and good afternoon to everybody, good morning, wherever you are. And I'll begin to make an overview about our local and national system, because the Italian national system is a public system organized on regional basis and divided in local unit. Specifically, our local unit, local social and health unit, covers a territory of 1,240 square kilometers. It had 59 municipalities and is divided into 2 districts. And it covers a total population of 500,000, more or less, people. And it provides to citizens, through the structures and offices, collective prevention, primary care medicine, specialist medicine, hospital care, and social assistance, residential health care for dependent, and long-term care. We've got 6 hospitals in our territory, organized in a network based on the hub and spoke system. And I'm now speaking from the main hospital, that is the hospital of Vicenza, named San Bortolo. That is the hub hospital and covers approximately 800 beds for patients. And to make an overview on our national system, if we can go, okay, the sustainability of our system, the resilience and effectiveness are primarily influenced by 3 major themes, as you can see, and the demographic transition, which, you know, Italy is the 2nd oldest country in the world, and our main average age is increasing every year by now. And another pillar is the care demand, and of course, with this demographic transition, the care demand increase, and the resources that are human and financial. And regarding the first point, as I said, the demographic transition is increasing. And about the resources available, we had an overview of, if we can go, Erika. Okay, we had a scenario where we had got less medical and nurses care and staff, which is due to also a great flight of doctors and nurses to other countries. And furthermore, we've got our financial expense based on our spending that are decreasing every year by now. As you can go, Erika, again. We now had a decreasing in the public expenditure that had an increase in the COVID period, of course, but now is decreasing rapidly and tend to more or less 6.2% of our product, gross product. And this overview is to make sense that we've got, with all these factors, create a challenging scenario for our national system. And now we'll hand over the floor to my colleague Erika.
I'm speaking about the central surgical block. In the central surgical block work 10 different specialties, sharing 10 rooms. 2 of them are for emergency. 130 staff people run the system. 11,000 scheduled interventions have been performed in 2022. 2,600 types of medical devices have been managed for a total cost of 5 million. The rooms are scheduled from 7:40 a.m. to 8 p.m., when the last scheduled intervention should have been finished. It's very important to maximize their utilizations, because the operating rooms cost is from 22 euro to 130 euro per minute. Every delay over 8 p.m. of the operating room double or triple cost, assuming the staff is available. In October 2021, we studied the operating room process and asked to staff to record for some weeks all reasons of process interruption. One of the most frequent was related to the time spent by surgical nurses to manage the medical devices. So we start our improvement from there. For each surgical specialty, a surgical nurse is referent for materials. He is involved in the tender phase in the selection of medical devices. He knows real consumption and needs. He does import order to suppliers. He checks stocks and medical devices, deadlines, and replenishes medical devices, taking them from a room where all devices are stocked. A lot of tasks in a short time. So the surgical nurse order large quantities of medical devices few times a year in order to feel himself more confident that he will not run out of materials. But medical devices expire. The surgeon changes the surgical approach and medical devices. The suppliers change due to the tender deadline. Each of these situations causes stock materials to be unusable, higher stock, higher losses, higher difficulty to find the right device when needed. Each specialty orders its own medical devices, and very often the same material is ordered by several different surgeries. Medical devices arrive in central warehouse, where they are stocked to each specialty area. We can't quantify the losses because materials are, in that moment, accounted to the specific specialty as used, but actually these are in warehouse, not used yet. So it's impossible to understand how much material is actually used and how much actually discarded. It was done a micro-estimated of the time the surgical nurse takes to restore the cabinet by picking the items from the central warehouse located 2 floors down. Each one spends about 1 hour a day restoring materials. In total, for 10 surgeries, this is equivalent to 10 hours a day. Here we can see the medical device flow, example from maxillofacial surgery. When arrived from suppliers, materials are stocked in maxillofacial surgery area of the room used as a warehouse. The same material used by different surgeries is placed in several areas of the warehouse. The medical devices are moved from warehouse to cabinet outside the operating room by surgical nurse. Often he takes as much material as possible in order to reduce the movement to and from the warehouse. The medical devices in cabinets are used to restore the operating room trolley. Our objective, our goals are reduce material losses, reduce non-value added activities time of surgical nurse. Our countermeasures are setting a formal operating group warehouse, maintenance of minimum quantity in surgery rooms, cabinets, and trolleys, Kanban replenishment of devices in the room cabinet by dedicated staff. Let's see the future states of medical device flow. In future state, the operating room pull the medical devices from cabinets outside the operating room and, when reach the order point in the cabinets, are replenished from the warehouse on a daily basis by dedicated warehouse workers. The same is made with suppliers. A warehouse manager orders the material on behalf of all surgical specialties. The materials are digitally loaded to operating group warehouse. They will be accounted to the specific specialty only when moved to the specific cabinet in operating room area. In this way, we can also know the real consumption of materials. The project started on March 2022. We started work with the rooms trolley, then on April with specialty cabinets. From March to August, we worked at the central warehouse, and on September, all the surgery specialty were able to work with Kanban replenishment. The material are restored by dedicated resources on daily basis using a Kanban list. On January 2023, we made the warehouse inventory, align the actual quantities with the system data. But there is still work to be done. Next areas of improvement we are working on are setting a digital Kanban, reducing the internal lead time from warehouse manager order request to ordering to suppliers. Now the internal lead time is 3 weeks. That means a higher order point for any material. In the operating room, we set 2 trolleys of materials. One stores the materials used by anesthesiologists, and a smaller one contains the specific materials of the specialty. For every trolley, we applied the 5S: separate, set, clean, standardize, and spreading the method and sustain to all 10 specialties involved. Before, the materials were stored like a treasure hunt in order to stock as much material as possible. As you can see, initially, the materials were positioned haphazardly and therefore hard to find and to understand the quantity. Each device is identified with company RIF and internal pharmacy code, shelf position in all cabinets and in the central storage, stock and visual order points. Here you can see some examples where, with simple materials, we have been able to improve the visibility of the materials. With the cardboard, we created a grid where you can see at a glance if the material is present or needs to be restored. We defined the order point with the colored tape. Once all cabinets outside the operating room were set, all surplus materials were returned and loaded to the central warehouse, and part numbers from multiple specialties were grouped in the central shelves. The specific specialty materials are stocked on the lateral shelf. The material management standard is loading from inside, picking up from outside for middle row, picking from top to bottom and from left to right. Every morning by 9 o'clock, after replenishing the operating room trolleys from the cabinets, the nurse, based on the visual order point, filled the replenishment list, which needed device, sending to the central warehouse. The warehouse manager replenishes the required devices to the cabinet by 2 p.m. The first goal achieved was to free up the time of the surgical nurse, and he no longer has to worry about the replenishment of the materials from the central warehouse to the specialty cabinet. Now we know the real consumption of medical devices and how many are discharged, very few, because expired. A new standard to request the material was implemented. Now it's possible to understand the actual consumption of material, and the physical stock is aligned with the digital one. Spending on medical devices was reduced by 600,000, despite 2,000 more interventions performed in 22 versus 21. Next step we are working on is using an electronic Kanban directly inside the operating room, scanning the medical devices when used on the patient during the operation. This permits the traceability of each medical device used with the specific patient. The warehouse manager is informed in real time about what is consumed. The warehouse manager saves time avoiding to input manually consumption data on the NFS system. Using the electronic Kanban that sends signal in real time to the warehouse permits a short replenish lead time. That means a lower inventory in the cabinets outside the operating room. Also, we are working to reduce at 1 week the internal procurement process lead time, actually 3 weeks. That means a further reduction of materials in the central warehouse. When we start the project, we have reported here the most common phrases that we have here from surgical nurses in the operating group when we started the project in March of last year. We came from 2 years of COVID. We are tired of more instability. If I change the position of the devices, colleagues become decompensated. I have to teach my colleague a new method. What if I am an emergency and a device fall out? I don't have the space. I can do better than this. My glasses. You're not going to move my surgeon glasses, are you? And finally, the voice of the Gemba. is the real experience of two surgical nurses. On the left, the surgical nurse who starts first with the project, and on the right, you can see the surgical nurse who is skeptical initially.
Buongiorno, sono Massimo Fornaser, referente della sala Otorino Maxillo di Vicenza.
Bene, Massimo, come ti sei trovato con il nuovo sistema
Oh, sorry?
di riapprovvigionamento dei materiali?
Allora, siamo partiti per primi dalla nostra sala, mi trovo abbastanza bene. L'unica problematica che c'è stata è stato praticamente la grande quantità di materiali che noi abbiamo, e tracciare tutto non è stato così semplice perché non abbiamo armadi dedicati alle varie tipologie di prodotto.
Ok, e quindi hai incontrato questa tipologia di difficoltà? I benefici?
I benefici sono che con il tempo si sta sempre migliorando la cosa, nel senso che anche i magazzinieri stessi all'inizio avevano difficoltà a comprendere tutti i codici, tutti i prodotti e a capire dove posizionare i materiali. Col tempo abbiamo sempre più ottimizzato la cosa e mi sembra che i materiali in questo momento vanno dove devono andare.
Bene, e il rapporto con i colleghi?
Il rapporto con i colleghi è un po' particolare, nel senso che non sono ancora, secondo me, entrati in questa linea che ogni giorno bisogna fare questo lavoro. Sicuramente non aiuta ad oggi la tempistica, nel senso che avere la possibilità di fare magazzino solamente dalle 9 alle 11, un po' come richiesta di materiali, è un po' limitativo perché tra malattie e problemi di personale ci può essere difficoltà e che non venga fatto il lavoro.
Bene, Massimo, grazie mille del tuo contributo.
Now you can see Loredana.
Buongiorno.
Sorry. Ok.
Allora, chi sei?
Buongiorno a tutti, Loredana Maltauro, strumentista della chirurgia plastica, referente.
E come hai vissuto l'esperienza del nuovo sistema di approvvigionamento dei materiali?
Ok, allora è stata un'esperienza all'inizio un po' destabilizzante perché non sapevo a cosa andavo incontro, ma vi devo dire che con l'aiuto di Erika che ci ha sostenuto fin dall'inizio mi è nato un entusiasmo e una cosa di rivisitare il tutto e mettere ordine e chiarezza nella cosa che mi è piaciuta davvero tanto.
Quali difficoltà hai incontrato?
Allora, ma difficoltà, se devo essere sincera, nessuno, anche perché ho avuto la stretta collaborazione di persone che avevano le loro esperienze e quindi le loro indicazioni. Per cui direi che difficoltà non ne ho riscontrato. Ecco.
E il rapporto con i colleghi invece?
Allora, mi è piaciuto anche questo aspetto in quanto io avrei la tendenza a condividere sempre con le persone che mi stanno vicino. Con i colleghi è stato proprio questo tipo di rapporto, di relazione e potendoci scambiare quindi delle opinioni, delle informazioni, siamo riusciti a completare e a migliorare questo sistema, questo approccio iniziale che avevamo programmato, insomma, che c'era stato anche proposto, ecco.
Bene, grazie mille.
Grazie a voi, scusate.
Thank you so much
Okay,
for your attention.
thank you, Erika. I would like to add a couple of comments because I was the lean coach that helped Erica and other people to do the job. As you have been able to see, this has been a good project. It's the first project of the company or the hospitals, and in parallel of this, other projects were led by Erica, and nowadays another is starting this moment with a complete departments, so with many people involved. What was important in this project was the starting and the support that was given by the director, because in some situation it's not so easy, and it helped to win against some resistances that were along the project. There is a question from Anton Iacuni. Anton, more than a question, is a comment. Would be cool to make the shelves to account usage. And okay, right, because at the beginning, the idea was to account the usage directly inside the room. But as a first project, we consider that it should have been some risks, because if you have to account the usage inside the room when you are in a hurry in making the intervention, so it's not so easy that people inside the room is able to actually account what has been used. So the decision was to have inside the trolley the quantity of material for 1 day. And so the nurses, while he is using the material, at the end of the day, he or she goes out and replenish the material directly from the cabinet, where 2 days of materials are stocked. And so this is the moment where they are able to make the order to the central warehouse. So actually, what is replenished in the cabinet is not really used, but maximum we have 3 days of material between the cabinet and the trolley. So this was the first situation. It is not excluded that in the future, when people take some kind of confidence with the system, and so when we arrive to that situation, we can move the usage accounting directly in the room. A second comment, I meant to make the share to account automatically. Yes, this is the next again, Anton, is the next step. But the problem nowadays is the information technology department of the hospital that has some problems, but is one of the next improvement that Erica was talking about before. Thank you, Anton. You can see probably, Erica, the comments. Anyway, impressive works, guys. Thank you so much for sharing. If any other question, we have another minutes. No, yes, thank you for claps. Hey guys, so we can close the webinar now. You can review it in some weeks, because all the webinar has been recorded. So when it will be done, you will receive a kind of link to permit you to see again. Thank you very much. Bye bye to all of you.